Now, let's turn our attention to the many different drugs that are used in the context of hyperlipidemia in order to lower lipids. Before we start talking about the various classes of medication, let's briefly review how cholesterol and lipids work in the body. Cholesterol is either absorbed from the gut or synthesized in the liver. From there, it can be converted to bile acids and then secreted into the gallbladder, or it can be converted into very low-density lipoprotein, or VLDL, which circulates in the blood. As VLDL circulates, it is converted by the enzyme lipoprotein lipase into low-density lipoprotein, or LDL, and can be reabsorbed back into hepatocytes. With that overview under our belts, let's get into some of the drugs. As we go through them, we'll focus on how each of the drugs affects the three most important serum lipids: LDL, HDL, and triglycerides. We'll also focus on mechanism of action and on some important side effects. The first class of drugs are technically called HMG-CoA reductase inhibitors, but they're commonly known as statins, since most of the drug names end in statin, as shown here. These drugs all inhibit the enzyme HMG-CoA reductase. Makes sense. This enzyme is responsible for synthesizing cholesterol in the liver, therefore these drugs lower cholesterol synthesis. Since less cholesterol is synthesized, more LDL is removed from the serum into the liver. Therefore, the main effect of statins is to lower LDL. There can also be some increase in HDL and a slight decrease in triglycerides, but these effects tend to be minor. Common side effects you should know include hepatotoxicity and muscle irritation, either myositis or frank rhabdomyolysis. The next class of drugs is really just one drug, namely niacin. The primary use of niacin is to increase HDL, although it can also lower LDL and slightly lower triglycerides. Niacin works by reducing secretion of VLDL into circulation, and also by inhibiting adipose tissue lipolysis. The most common side effect of niacin is a red, flushed skin reaction, especially on the face. Now, this doesn't sound that bad, but it's a very common reason why patients might actually stop taking this drug after it's prescribed to them. Luckily, it can be limited by taking aspirin beforehand. Additionally, hyperglycemia and hyperuricemia are possible effects, so niacin should be used cautiously in patients with diabetes or in patients with gout. Next, let's talk about bile acid resins, such as cholestyramine. These drugs work by binding to bile acids in the intestines, preventing them from being reabsorbed back into the blood. This class of drugs is mostly used to lower LDL, but because it tastes really bad and it causes unpleasant GI side effects, it has largely been replaced by statins for most patients. Now, there are some patients who benefit by a combination of these two drugs. One important indication for cholestyramine is in combination with a statin if a patient's LDL really needs to be lowered. The next drug to consider is ezetimibe, which directly blocks cholesterol absorption from the gut. This drug also decreases LDL, and similarly, statins have replaced most of this drug usage. However, it also works synergistically with statins to help lower LDL in very high-risk patients. It's usually very well tolerated, but rarely can lead to an increase in liver function tests. The final class of lipid-lowering drugs is known as fibrates, which you can recognize by the FIB in the middle of each drug name. These drugs are very effective in lowering triglycerides. They work by enhancing the activity of lipoprotein lipase. This works by increasing triglyceride clearance and therefore lowering serum triglyceride levels. Toxicities include myositis, hepatotoxicity, and cholesterol gallstones. Okay, now I know that was a lot of detail about how to lower lipids, so let's review this information with a mini case. Ready? A 56-year-old man presents to his physician for routine annual lab work. His lipid profile is the following: LDL 165, HDL 23, and triglycerides 145. Which drug or combination of drugs is best suited for this patient? Simvastatin alone, simvastatin and niacin, niacin alone, niacin and gemfibrozil, or simvastatin and niacin and gemfibrozil. If we look at this patient's lab work, the patient has a high LDL and a low HDL, but a pretty normal triglyceride level. So, the patient needs a combination of drugs that will both decrease LDL and increase HDL. Simvastatin, you can tell from the name, is in the class of statins, so it will work to decrease his LDL. Additionally, niacin will work to increase the patient's HDL. So these two are excellent drugs to consider. Gemfibrozil, we can also tell from the name, is a member of the fibrates class, so it would work to lower triglycerides. However, this patient's triglyceride levels are normal, so it's not necessary in this case. Therefore, in this case, the correct answer is simvastatin together with niacin. Also, one important side note here is that statins and fibrates, such as simvastatin and gemfibrozil, should only be used together with very extreme caution, since the combination of these two can greatly increase the risk for rhabdomyolysis. Now, let's move on to discuss some of the drugs used in treating heart failure. The first group is known as cardiac glycosides, including digoxin and digitalis. These drugs work by directly inhibiting the sodium-potassium ATPase in cardiac muscle. This increases the intracellular concentration of sodium, which then increases the exchange of sodium and calcium. The end result is an increased intracellular concentration of calcium, which leads to increased contractility. The increase in contractility is why these drugs are useful in patients with heart failure. Additionally, cardiac glycosides also stimulate the vagus nerve, so they can be useful in arrhythmias such as atrial fibrillation. Common toxicities can include cholinergic effects, such as nausea, vomiting, and diarrhea, as well as EKG changes. Also important to know is that these side effects can be worsened by renal failure, hypokalemia, and quinidine by the mechanisms that are listed here. In the event of severe toxicity, which you'll hear in the hospital as dig toxicity, treatment includes normalization of serum potassium as well as anti-dig antibodies and some other therapies that are listed here. Another drug commonly used in heart failure is known as nasiritide. This drug is a recombinant form of B-type natriuretic peptide, or BNP. It works to promote vasodilation by increasing cyclic GMP, the similar mechanism that we've already seen. It's very useful in acute decompensated heart failure, but it can also cause hypotension, so it's something that should be used very carefully and only under select circumstances. To finish up with cardiovascular drugs, we're going to spend some time talking about anti-arrhythmic drugs. Now, as you can see from this fact, there's a lot of information to be learned here, and a lot of students find it hard to keep all the details straight. To be honest, it will take some time to learn this information in the level of detail that you're going to need. So for now, we're just going to focus on the concepts, but please make sure to come back to this information during your studying. Before we get into any specifics, let's just be clear about how antiarrhythmics are categorized. The drugs are split into different categories based on how they work. Class 1 antiarrhythmic drugs are drugs that block sodium channels. All of these drugs slow or block conduction, and they do so more effectively in cells that are frequently depolarized. All Class 1 drugs slow down phase 0 of the cardiac myocyte action potential, also known as phase 0 depolarization. Now, within Class 1, we can further split up drugs into subclasses A, B, and C based on the specific details of their pharmacokinetics. Class 1A drugs prolong phase 3 of the action potential curve, and they do so most drastically. This class includes quinidine, procainamide, and disopyramide. Class 1B drugs prolong phase 3 the least. This class includes lidocaine as well as some others that are listed here. Finally, Class 1C drugs are in the middle as far as prolonging phase 3, and these drugs include flecainide and propafenone. Because of the differences between these three subclasses, these drugs are used in different clinical settings. The explanations as to why are beyond the scope of this lecture. However, you should remember that Class 1A drugs are used mostly in atrial and ventricular arrhythmias. Class 1B drugs are used mostly post-MI. Class 1C drugs are most useful in life-threatening arrhythmias, such as intractable SVT, VTAC, or VFib. The next class of antiarrhythmics is Class 2, which is the class of beta blockers. This includes various drugs listed here, all ending in olol, including propranolol, metoprolol, and atenolol, to name a few important ones. These drugs work by directly antagonizing beta receptors, which decreases cyclic AMP and thus intracellular calcium. They work as antiarrhythmics primarily by suppressing the AV node. Therefore, they are primarily useful in a variety of conditions, including VTAC, SVT, and AFib and A-flutter. Common side effects are listed here. One particular side effect that I'm going to point out that's very high yield on the exam is masking the signs of hypoglycemia. Therefore, these drugs, if used, need to be monitored very carefully in patients at a risk for hypoglycemia. Next, we have Class 3, which is the class of drugs that act by blocking potassium channels. This includes a number of drugs listed here. The drugs work by increasing the duration of phase 3, but they also increase the QT interval. Because of this, there are some important toxicities to keep in mind. First, we remember from our discussion of Torsade that any drug that prolongs a QT interval can lead to Torsade, and these antiarrhythmics are no exception. Additionally, amiodarone has a number of very specific toxicities that are high yield to know for the exam, including pulmonary fibrosis, hepatotoxicity, and hypo or hyperthyroidism. As a result, any patient taking amiodarone should be monitored with pulmonary function tests, liver function tests, and thyroid function tests. This tends to be a very high yield fact on the exam. Next, we have the Class 4 antiarrhythmics, which are calcium channel blockers. We've already started to discuss this class of drugs, but in terms of their antiarrhythmic activity, they work by decreasing conduction velocity, and they have the effect of increasing PR interval. They're used primarily to prevent nodal arrhythmias, such as SVT. Notable side effects include constipation, flushing, edema, and, interestingly, some cardiovascular side effects, including things as severe as CHF or AV block. Finally, let's mention some other antiarrhythmics. First, adenosine works by driving potassium out of cells. It's very useful in abolishing or even diagnosing supraventricular tachycardia. It's important to know, however, that it's extremely short-acting, on the order of 15 seconds. Also, it can have severe toxicity, including hypotension and chest pain. So this is a drug that should be used very carefully under very controlled clinical settings. Last but not least, we have magnesium, which is used primarily in Torsade and digoxin toxicity. Magnesium has this effect because it often acts as a cofactor for ion channels and therefore allows for regulation of current. Magnesium can also be an important drug to consider because magnesium deficiency tends to amplify certain arrhythmias. Okay, that's it for the cardiovascular section. Please remember to take the time to learn the physiology and also to take the time to memorize the details that need to be memorized. The rest will fall into place. Happy studying!